Welcome to the Reverse Mullet Healthcare Podcast from BP2 Health. Today we're talking about AI and real change in the healthcare industry. But first, who are we and why are we here? Most importantly, why did we name our podcast the Reverse Mullet Healthcare Podcast?
That's a good question. We want to be relevant, informative, and creative. We also want to be entertaining and have fun. So it's party in the front and business in the back.
All right.
Like a mullet, only reversed.
I'm Ellen Brown.
I'm Justin Politi.
And I'm Dave Pavlik. We are passionate,
Innovative and collaborative. And we're committed to solving our industry's most important issues together with our clients. We have a combined 90 years of experience. I don't have a radio voice, but I can do this.
No, but that does make us sound so old.
Yeah, no kidding. In each episode, we're going to dig into a hot healthcare topic and dig into each other a little bit.
Just be gentle on me, please.
Nope, noogies. We're giving lots of noogies out today.
I'm really excited about today's topic. And it's not just because we're talking about AI, it's because we're talking about change, okay? So I would say that although Americans cannot agree on much of anything these days, I bet if we went out on the street and we did a poll, which we're not doing today, one of the things that they do agree upon is that our healthcare system is broken. It's complicated, it's expensive, it's dysfunctional and fragmented. Our own tagline, I think I can get it right today, your best chance for real change, was born out of a true desire to fix it. So in this episode, I thought it'd be super fun, and you guys finally came along with the idea of if we came to the table.
Twisted our arm.
Yes,
Yeah,
I did.
all right.
I did. I wouldn't hurt you, though. I thought it'd be really fun if we came to the table and we shared what each of us thought was most needed to change, but the spin is that we haven't shared with each other ahead of time what our own ideas around change are.
You know, I'm thinking this has to have 80 million different options of wearables associated with it. There's got to be some.
No, I will give it away now. I don't talk about
No,
wearables.
but here's the other thing, though. If we all pick the same thing, it's going to be a really short episode.
Okay, well,
It is.
I know, but we all told Kim ahead of time, our producer, what our topics were, and she made sure that we weren't overlapping.
Good point. Well, let's get started. But before we do, we always got to do some party in the front, right?
I have something for you guys today.
Oh, yeah?
Oh, yeah. So last time when we came into the studio, because this is now our second time in the studio, so we're not newbies at this anymore, there was something that we needed that we didn't have. So if you guys could close your eyes, please.
Wait.
I'm not doing that.
Last time
No.
this happened,
All right, fine.
All right, close my eyes are
I'm
closed.
going to go into my little
All
bag
right, my
because I
eyes are
have
closed.
goodies for like each episode
Okay, eyes are
today.
closed, not
Okay.
peeking, not peeking.
So I have one for Dave. Not yet. And then I have one for Justin.
It's round.
So
it's round.
it's round. Oh, no, I haven't put it under your hand. There you go. Okay. So Justin, push your round thing first.
That's the boring button.
I got a boring button. But no, there's one that you guys don't know at all about. Dave, touch your button. What does it do? Okay. So we have buttons now.
Okay.
That's
Yeah,
awesome. This is going to be going 24/7.
This
Yeah,
is, and the problem, if everybody noticed, I didn't get myself a button because guess what? Those buttons are going to 100% be used for me. Like, I don't think I ever, like, literally, I think you have the buttons. I think you need to put the button in between. Justin and I will share a button. But honestly, the button's really for me.
Let's not overuse the buttons, though.
No, we won't.
It's tempting, though.
I know.
Yeah,
I already want to do it on you right now. So
Okay.
wanna talk?
Okay, so before we jump in, a shout out to our sponsor today. We have a different sponsor today. Our friends over at Accretive Health Advisors. We were pretty excited for them because they were just instrumental in getting the deal done between Walgreens and Pearl Health, one that a lot of people are talking about. So we thought it'd be fun to give them a little bit of a shout out today, but they got that across the finish line.
Yes. Accretive Health Advisors is a healthcare-focused advisory firm focusing on investments and growth around value-based care delivery through primary care. They believe, like us, a shift away from transactional fee-for-service care arrangements aligns with patient experience, patient outcomes, and clinicians' quality of life with financial performance. Accretive Health Advisors serves both independent physicians and healthcare investors in developing growth strategies, physician practice valuation, brokerage services, and M&A process development. They are at accretivehealthadvisors.com.
You may have to look up how to spell accretive. I feel like that's one of those words that like maybe everybody doesn't remember.
ACCRETIVE.
There you go.
Right. There you go.
CreativeHealthAdvisors.com. Okay, so to kick this off, we're going to talk about change today, right? So let's put some context around this and see if we can agree upon the fundamentals of what's broken without giving away what we each plan to share. So my daughter, Sophia, we talked about this last time. All of our kids are now in college or out of college. Well, no, my youngest is in high school, but my daughter's in college. I can't believe I'm like acting like I've forgotten that my son is still somehow in high school. Anyways, my daughter is definitely my daughter. She's taking microeconomics, and she calls me after the first week of school and says, "Mommy, my microeconomics professor was actually teaching us about failed markets, and he used healthcare as the prime example of what a failed market was." So, of course, that harkened me back because I have a degree. One of my degrees is in economics. And so I was trying to recall, sadly, I didn't even remember what the definition of a failed market is. So that leads me to a definition.
Here we go.
Of course.
Yes. But guess what, Justin?
All right. Okay, let's go. Keep going.
Okay.
Yep.
Guess what, though? I used Britannica. So Britannica actually came up. So when I put in what is a failed market definition, Britannica was the first thing that came up. So there you go.
That's right. We're going to use Funk and Wagnalls when we get to a future episode. I'm going to introduce that
okay,
right
fine.
now. So
It
anyway.
is your job to find Funk and Wagnalls like online, but I can't find it. I think we might have to find somebody with a Funk and Wagnalls set. Right?
They split it in two. So you get half the dictionary. Like if you only get half the dictionary, you only learn half the words.
Well, it's like a subscription, right? So
Yeah,
I
you
remember that.
stamps back in the day.
Yeah,
You
It was
bring them back.
1960.
Yeah.
We're talking
No,
about-
I was okay. Anyways.
All right.
So the definition was that the market incurs too many costs or receives too few benefits. It was like a super simple definition, honestly. But after kind of going through this at a sort of more intellectual level, I don't disagree with Sophia's professor, but I can't give up on healthcare because we need it. It's not optional, right? It's not a market that's optional. It's a matter of how do we do it.
Yeah, but before we go on, I think it's important that before we share our ideas, we need to agree upon what the goal is, right? What's the goal for change? Can we all agree that to reduce the overall costs in the healthcare to society while not diminishing quality is the goal?
Well, I'd say broadly, yes, but there are some nuances to that, right? Like there are areas that are underinvested in right now within the sector that actually do need. So it's not broadly that we're reducing costs for everyone. I think it's
absolutely.
that you've got to
Overall.
But the goal
overall.
overall of change, when we talk about change, is that we have to take costs out of the healthcare
Of the system, yeah.
Okay? So that's kind of the goal when we talk about these things today.
So we're in agreement.
And we all agree, but I will say I am extraordinarily skeptical, and I will put this challenge out to all the leaders. Maybe these leaders won't listen to us anymore, but I will put the challenge out that are you willing to take costs out of the system? Because the problem is that these folks are part of the healthcare delivery system. They drive it, and we have to be willing to take. So that means big change. It means massive layoffs. I struggled whether I wanted to use the word massive, but it's got to be significant. The elimination or repurposing of healthcare facility capacity. We have way too many beds in the wrong places for the wrong things. Like, I'm just saying it. I'm just putting it out there. It's not going to be popular, but I think we have to know that that's got to happen. So in the perfect world, let's pretend that everybody's on board with that, okay? With the idea of we're going to take change out. And I'm going to start with you, Dave. So what are your two picks? We only get to do two.
My two picks, well, my first pick is administrative burdens. Reducing the amount of administrative burdens in the system, because those affect...
Sorry.
So, okay.
on to the next.
No, you can talk about it. I just want to.
Think about it though. Think about it though. These administrative burdens affect patients and providers and payers. They've all got some kind of administrative burdens that are just too much, right? Causing delays in care, causing decreased patient satisfaction, increased financial burden. I mean, the list goes on and on. For providers, it incurs additional costs, decreased productivity. They get burned out, right? And a lot of that. So think about it.
Like the Kaiser strike, right? That whole Kaiser strike.
Yeah.
So
And that's
and one of the big contentions there was not enough staffing, too much administrative burden, not able to render care the way they wanted to render care.
And some of these things, like one of the big ones is prior authorization, right?
Yeah, you're talking about
geez.
getting in the weeds of all the minutia of things that,
Right.
like, it's hoops that you just have to jump through in order to get something done, and to what end?
Yeah,
You know what I
and
mean?
right. So, I mean, the payers have these requirements for prior authorizations, one example, but the payers also have to jump through some hoops when it comes to some of the burdens that they have to deal with, and it reduces their revenue. So it's kind of like it's almost like a vicious circle.
It is. I don't know. I mean, but I feel like there's definitely something there that, you know, that I would agree with. I also think that, you know, a lot of our infrastructure is basically built to, like right now, is built to just have those workflows built into it, you know, systemically.
It's like legacy.
It is. It's just like, hey, you know, it's like the whole fee-for-service system going back to that. But it's like, hey, we've got this infrastructure here, and there's these justifications along the way instead of like, to your point, I guess, is just like, all right, what would it look like? Imagine it if there was none of this stuff there.
Mm-hmm.
So kind of going back to the basics.
Yeah, but I do think that if everybody worked together, right, payers, government agencies, providers, right, all of them work together, there are ways to streamline some of this stuff, right? Yep. There's technology that can be used to automate some of it, and that would, imagine if some of it was eliminated completely, right?
I just had this flashback, and it's bizarre, but do you remember that commercial, If I Could Buy the World of Coke?
Yes.
Yes. Yes.
And how uplifting it was, right? But
Perfect
just going
harmony.
So good you guys can sing. I will never sing on this podcast.
But
or
I just
people
had
will
this
stop.
thought, this random thought of like, wow, that's the utopia right there. And Pete, you're up on a hill with a Coke.
I'm thinking of like a lighter at the
Yeah,
concert, and we're all I could sing Kumbaya too. That harkens me back to my youth.
That'd be excellent.
No, we will not do that.
Oh, please, okay.
Stream of consciousness.
But we do
Yeah,
have
yeah.
to play nicer in the sandbox too.
Yeah. My second one is expanding telehealth.
Yes.
And I know, during the pandemic, there was a lot of telehealth expansion. There were some waivers put into place, and some of them became permanent, right? I guess it was determined during that couple of year period that it made sense to leave some of this stuff in place, but there's still a long way to go. There's still a lot more. I think there's still a lot more that can be done to expand services to more people, especially those that are underserved or in underserved areas, I should say.
Honestly, it's a real solution for rural health, for rural
Mm-hmm.
communities. But again, it goes back to the payment system. We don't have a payment system that allows us to use telehealth the way that we want to. Like, to your point, there was waivers and things like that, but it's not adopted. It's not, doctors are not equivalently paid.
Right.
Because
for an office, as they are for an office visit.
Right, but the truth is, if they're still sitting in an office, like, why do we have to reduce their payment? I mean, if they're
Right.
spending their time and they're providing care, like, I honestly don't care whether a portion. I understand that the way that the Medicare fee schedule was created, that there's a portion of that for the technical component, right? For the fact that they're leasing an office and they have medical supplies, whatever. Like, all of that is baked into the base rate that they're getting paid. But so what? So
They're still in the office doing the visit, and so there's still
right. I don't even care if they're in their house. I mean,
there's no incentive for them to take on a visit that they get paid half for.
Exactly. So, like, I have a doctor myself who, during the pandemic, was all online. He's all telehealth, and it was fantastic. It was because he was 2 hours from where I lived. I mean, what a waste of time, right? Plus, he can't ever stay on schedule, and so if he was an hour late, I could just sit and do work. I wasn't like sitting in the waiting room with a book, but he did away with it because he doesn't get enough money.
So, I mean, first off, I think we're smart enough as a society to be able to get to this solution, to get a solution on this, being paid adequately for
I
those
agree.
services. And it leads into one of mine.
So is it time to switch to you?
Well, I'm all
Is
I'm
there
going to say
anything
is
else, Dave, that you have passionate to say?
No, well, just that what you just said, 100% agree with, but some of the problem is kind of outside of the healthcare system. For example, access to the internet from some of these rural areas.
Technology.
The healthcare system can't solve that. We have to solve it as a nation, right? And also a lot of the states just have regulations in place that don't
Yes.
allow certain specialties to do certain things remotely. So that's got to be done at the state legislature level.
But also, again, bringing it back to this, Walmart as an example, Walmarts are everywhere, right?
And in Florida, they are opening up clinics like there's no tomorrow.
And now they have virtual clinics. So they've entered, it's called the Walmart Health Virtual Primary Care offering. And it's, if you go to it, it's full spectrum, 24/7. And this is kind of, from my perspective, where I think healthcare needs to go or will be going, where you're not going back or just going to your primary care face-to-face, in the future.
Right.
You're going to be able to have more real-time access, and you're going to have stuff available to you in your home, like, blood pressure sleeves, things that are a little bit more sophisticated, that can do all the things that are when you're in a primary care office that you can take care of from the comfort of your own home. It's like going back to the robot discussion we had last time, but you have a virtual person, and whether they're,
What's the name of your robot again?
Twiggy.
Twiggy.
Yep.
Twiggy or Tweaky?
Twiggy.
Twiggy.
No, Tweaky.
Twiggy. Okay,
It's in between. I'll cut myself off there.
Well,
So
it's your
that was
turn.
one, right?
that's that. Yeah.
But
that
I'm
was
self-regulating.
yours.
Right, yeah.
So
the
there was
Walmart
like some overlap. Oh.
And then the other, so
You
there was
actually-
overlap.
Okay, so I'm
You
going to
segued
stop
into
you
it.
there. All right, but that's a little bit like overlapping, the telehealth and then the virtual prime. Like I'm not critiquing, just saying that they're a little bit.
I told you
bit
we might
similar.
pick
Similar.
we picked
All
the same
right,
thing.
it is the risk of my challenge to you guys. Okay, but so before we go in the other one, so let's go back to the Walmart virtual primary care thing. When I say change, I don't mean little teeny incremental change. I just want to be clear. Like I'm talking about the big stuff. So your point, Justin, is this: is it that Walmart doing it because of who they are,
Yep.
right? Is that Walmart has the ability to disrupt the market?
Yes.
Okay, because people understand that brand.
Yep.
So then they go to the Walmart. There may actually be a clinic at the Walmart, even if they live 2.5 hours from the Walmart. They're coming into town on some. Either
Walmart
they
is
got a
healthcare.
ride in someone's truck, or they took a Greyhound or something. They get into Walmart. Oh, there's care here.
Yep.
And then while they're in there, they learn. Oh, I can do this online.
Yes, yeah.
Okay.
And so you've got virtual capabilities, to be able to help, but your link is the Walmart experience, right?
Okay.
So
there's
that's
kind
my
of two pieces to this. Walmart virtual care is telehealth, so they are the same. However, the first piece is we have to be willing to adopt telehealth. We have to be willing to reimburse for telehealth. We have to figure out how that becomes part of a true part of the healthcare delivery system, not an appendage. And then the second thing that we need to do is what you're saying, Justin, is I'm putting words in your mouth. Wait, hit the blah, 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 because that's what I'm just kidding. So what you're saying is it can't just be telehealth on its own. You also need to have a name behind it, right? Like we could fix all this stuff with telehealth, but having
the Walmart
disruptor
brand,
like
name,
Walmart do it.
locations,
Okay.
the physical
So like an
footprint.
Amazon-
So it's so
Right.
you're taking advantage of the physical footprint,
Yep.
brand recognition,
Yep.
the whole thing, along with, right, so, it's an overall experience, right?
Yep.
Virtual, in clinic if it's available, but that's your, they're the aggregator. That's what I foresee, just that they have that kind of,
They're embedded in life, in
And
culture,
society.
and society
Yep.
enough. Yeah. I mean, it's a shame that Amazon, their whole thing went belly up. They'll clearly,
come back.
I just think
they have to.
they'll come
Walmart
They
is
need to.
just different. It's just it's so ingrained versus a
It's like an
transactional
everyman.
experience. It is something. It's a physical location.
It's a low cost solution.
Yeah,
Right? I
and
wonder
it's-
what their brand thing is, their slogan.
that I don't know, but
Yeah.
but then I
Blue
just want
light
to pivot.
special in cardiology.
No, that's Kmart.
Yeah, that's Kmart.
And
Yeah,
Kmart
that's
is
gone.
no longer.
Yeah, my bad.
Yeah,
No.
see, that would be a problem. I don't think Kmart could do it because
So I'm going to pivot to the other one, which are these new weight loss drugs that are out on the market. Wegovy and Ozempic, right?
Okay.
So this is another component, right? How many times have that we work with physician organizations, Medicare Advantage plans, working on quality metrics, focused on hemoglobin, A1C, having the right, levels. Like everybody is hyper focused on all those. What if you could take a shot and all of a sudden you're not hungry anymore, or you don't have the cravings, the food cravings that are causing the obesity that are, that you're having to focus on. So that, the headline media right now is the cost for these particular drugs, and insurance companies are having to pay for this, but there's downstream costs that haven't been factored in at this point because there's disease prevention potentially down the line.
You're saying that they aren't factoring in cost avoidance.
They aren't factoring cost avoidance.
They're
seeing
stuck on the cost of
right.
the drug.
We're getting flooded with it right now because there's such a high demand.
Yeah.
But I think
we have a friend who did this. Same. And she wasn't morbidly obese, but she did it, and she's like, back to normal and feels really good. That's it. So.
Yeah, and Morgan Stanley, according to the Wall Street Journal, right, estimates that it reduces food cravings by over 30%, meaning like, all right, what's the downstream impact to our society when we're not having snacks and other components that are like to the food industry of, hey, all of a sudden people are eating a lot less because of the drug. And they're estimating that nearly 7% of the total population will be on these drugs by 2035.
All right.
Seems like a miracle drug to me.
There's got to be
skeptical.
Remember Olestra?
Yes.
Oh, man.
Let's not go down
No.
hole.
I know, but everyone was fat-free,
I know,
and then it disappeared. So you don't know.
Right, exactly.
You don't know what you don't know.
Right.
But it's definitely a Hail Mary towards the obesity epidemic. Can't say epidemic.
All right, Ellen,
All right,
you started
your turn.
this. So what are your two?
So I'm just going to go on record as saying that I wanted to pick payment transformation because I always say that if we don't change the kind of perverse incentive of paying for care consumption, which then leads to overutilization, unnecessary care, all this, right? However, we talk about it a lot. The last 3 episodes, we did an episode on VBC, on value-based care. We talk about this is what we do for clients so many times, right? This is like right in our wheelhouse. So I'm gonna do something different, and I'm gonna pick what is arguably. So I'm gonna pick 2 things. One is a way to take costs out of the existing system, and then the other one I'm picking is we haven't really talked about the root cause. And you hit it a little bit with telehealth. There's the barrier of telehealth is also societal poverty, where people just don't even have access to the technology, right? So the one I'm getting into, but I'm going to go, my second one's going to be the root of the problem, which is harder to solve sometimes. So first one is AI. That's like the topic, right? It's like the shiny object, and I'm a skeptic of it. I know, Justin, you're a skeptic of it. We all are kind of skeptical of it. But it's here. It's not going anywhere. It's got a tremendous amount of traction. And I'm not really happy that I'm saying this, but I do have to say, I think in theory, it could be quite transformative.
When you say in theory be transformative, like what do you mean?
Well, it's going to be ground shifting. It's kind of like the disruption thing. It's like what you talked about with Walmart, right? It really changes the game. It replaces bodies. So when we talk about taking cost out, I mean, it's either...
So you're talking about replacing humans.
That's the only way it saves money. I mean...
I don't know about that.
Okay.
Because,
No, but at the end of the day, someone's job has to go away to save money.
Well, then I'd be really threatened. You know what I mean?
Yeah, I know, but I still think in healthcare, for most things, the AI can help, but you still need a physician looking at it and checking the box.
But less physicians.
Yeah.
I mean, at the end of the day, it's either less nurses, it's less office administrators, it's less... I mean, even what you were talking about with administrative burdens. I mean... We got to take. That's why I'm being such a jerk about this. Like,
we're going to lose all of our
costs out.
What about, why does it have to be replacing someone? Why can't it be enhancing somebody to do their job faster?
Okay, but then you haven't taken any cost out. Now you're paying for AI, and you're still paying the same number of people. You're gonna have to. You have to have people come out of the system. I mean, we can agree to disagree. We do that regularly. So maybe we need a button on that.
We just lost all of our nurses and physicians.
I'm sorry. There are people that I really care about. But that's why in the front of this discussion, that's why I said what I did. Like, we can't talk about change if we're not. That's why it's not happening. I mean, it drives me friggin' crazy. It's like
But then can you see why people would be reluctant if the first thing you talk about is, hey, you're not going to have a job?
I would. Do you know how much I would love
I'd be like,
to
I don't want
sit
to do
with a
this.
hospital CEO and say, can we actually sit down with you and your board and talk about how to actually re-engineer your health system so that it's less expensive? There's no conversation like that because they still want to have the same margin. I mean, I'll have to go to my board and say, oh, I'm proactively taking revenue out and I'm proactively reducing
Yeah,
my margins.
that'll go over really well.
I hope that's okay with you. I mean, but that's the thing. Like, and I'm not saying you have to do that. Like, there are ways to replace the income with other things. Like, I really believe that. But I'm just saying, we got to take money out. So somewhere, right? So let me just hit on my 3 things under AI, and then I'm going to quickly talk about my second item because people only have so much time to listen to us talk.
Right.
Okay. But I knew this one was going to be exciting. No, don't hit it. Don't hit it. Okay. He's trying. All right. The button's not getting hit. So, all right. Administrative workflow. Bingo. Right back to what Dave said.
Yep.
So, with AI, it can do things like, I'll use an example, a chat bot, where things that right now are considered healthcare services, like first tier of patient questions and needs, medication, questions about medication, scheduling follow-up visits, forwarding reports to doctors. Those are some of the administrative workflows. Medical errors. This is a really big deal. So up to 70% of patients, for example, don't take insulin as prescribed. And there's actually an AI tool that they're developing that runs in the background that can solve that can catch when patients are not doing that. And it's kind of like a Wi-Fi router that runs. I'm not going to go into the details. Fraud, $380 billion a year in fraud, okay, in healthcare. AI is really good at recognizing. I'm looking at your face, Justin. It's like you're
I'm skeptical. All these numbers, right, when it comes to fraud are like fancy pants, but anyway.
All right, I got to throw numbers out so I can sound
I know,
smart.
But I'm like, all right, so where are we getting that $380 billion?
Okay, that's for another episode, all right? We can pick apart the numbers. I'm not going to go into that. And lastly, and most controversially, and this is your point about we still need a doctor, Dave, right, is medical diagnosis. However, there was a pretty interesting, and this is totally like cyborgs. My parents actually they go to movies every Tuesday because it's half off matinees, and they're so cute. And they were telling me how they went and saw there's some new movie that's about cyborgs and a cyborg baby and all of this. And then my dad's like, it's like AI. I'm like, exactly. But this example of AI technology was around breast cancer risk prediction. There's apparently at the University of Hawaii did a study that had an AI algorithm that can be trained to bring in a much larger set of images to compare. So whereas you would normally as a radiologist, kind of have your own mental inventory, this brings AI into the picture. And so to your point, Dave, you still have a doctor, you still have a radiologist,
Right. Yep.
but it's a much better comprehensive picture. Okay, so that's my first one. And my second topic is, you're going to think I'm totally crazy. Because
we talked about it last night.
We did. You guys looked at me, because I told you that I had switched my topic from what I told Kim, and you were both like, oh boy. So this is the root cause, though. This is a root cause. Food, our food system. I was going to choose wellness, but that's kind of a big word, and there's a whole bunch melted into wellness. So I went specific, and I went food. And, okay, so I'm going to throw a bunch of, this goes back to your point, Justin, about the drug. I'm going to the root cause, which is just don't have a food system that is making people addicted to this stuff, okay? So here's a whole slew of statistics, ones that I found and then ones that I heard on a podcast. So 1 out of 3 Americans are either type 2 diabetic or they are pre-type 2 diabetic. It's a complete lifestyle, okay, disease. Diabetes is a complete I brought it on myself disease. It's not type 1. I'm not talking about type 1 here. I'm talking about type 2, okay? And it's from unhealthy eating and a lack of activity. It is disturbing when you talk to doctors, the number of people that would rather lose a toe or a limb to diabetes than eat healthy. And it's because our food system is so confusing and it's so overwhelming. And processed food is killing us, okay?
But we now have drugs
I
that are
know,
going to help
but
with that.
could we not pay for the drugs? Could we just eat?
Be healthy instead.
I'm sorry. We don't need to have the kind of
No, I think what Justin's saying is
ultra-processed
people are like,
food.
I'm not going to lose my toe because I'm going to take these drugs.
I'm going to take the drugs.
Still
All
gonna,
right,
I'm just going to
fine.
keep eating the same
All right,
food.
okay.
Or I don't have the cravings anymore. Now, that does not get to the point of
No,
Ellen's
exactly.
like, hey,
No.
you should be eating healthy, right?
Right.
That's a whole
And
educational
then cut that
component.
whole
We don't have
drug.
the system.
Just cut that whole
But you
drug
can-
out of the mix.
You can mitigate it with like technology. We're seeing it happen. Like
Oh,
we're seeing in front of
absolutely.
our eyes right now of like, hey, you know, the reality is if you can cut these cravings out, then you might have a lot of costs that are going to get taken out. Ideally, in a, you know, by the world of Coke type situation, we are all eating healthy foods, and there's
I'm
other
not
stuff that
asking
is
everybody
available.
to go out and eat a salad 3 times a day. It's just this ultra-processed food
Right.
is the core of our diet. We talk about health equity. You know, one of the biggest problems is food deserts. And you know who has the food deserts? The lowest income communities.
Yep.
They are known food deserts, and all they have access to is crap, is to junk. I mean, that's just, it's the way it is. So I was listening. So, okay, 45% of all deaths from cardiometabolic disease, okay? An unhealthy diet accounts for up to 45% of all deaths, such as heart disease, stroke, and type 2 diabetes. 1/3, get this one, 1/3 of Medicare expenses alone are from diabetes. 1/3 of Medicare expenses are from diabetes alone. That is staggering. One estimate from 2016 study estimated that $260 billion was related to obesity.
But so I get all the statistics, right? But there's a behavioral aspect to this too.
I agree.
That just even if you have, you know, food available, meaning like how can you, a lot of the individuals, to your point, don't necessarily have choices and the best choices available to them.
I agree.
But there are also people who don't want to change habits.
Yep.
They're fine with where they are.
Yep.
There's also, you know, a depression associated with some of these, you know, components. So, you know, I just think it's that this is only one aspect, and there's a lot of underlying issues as to why the numbers are the way that they are.
I know.
Beyond
I
just
agree.
food.
Okay, so I'm going to say 2 things, and then I know we have to wrap it up because we're like getting to the end. I knew this was going to be a robust episode. So I was listening to Dr.
I can see you're very passionate about this,
I
by
could
the way.
spend episodes on this.
I know.
You guys know I have done so much reading. So Dr. Mark Hyman talked about this topic on a podcast I was listening to. He's an author, and he's a doctor at the Cleveland Clinic. And he said 11 million people die every year from eating ultra-processed food. 6 out of 10 people have chronic disease. Unprocessed food, ultra-processed food has been shown to cause cognitive behavioral issues. Okay, so a bunch of the behavioral health issues that we're dealing with, ultra-processed food. This isn't woo-woo. Our biology hasn't adapted to highly refined food. 60% of calories in so 60% of your calories are from highly refined food. 10%, just 10% of your calories from ultra-processed food increases your risk of death by 14%. I understand we could pick all these statistics apart, okay? But the good news is that we do, as an industry, there's a very small movement right now of food is medicine. And I'm so excited about this, like food is medicine.
I'd say it's larger scale than you're giving it credit for. When I say this, in that, you know,
I feel like it's still a little bit of lip service, okay?
No, I'd push back strongly against that. Boston Medical Center
I know,
has a
Tufts.
food pantry. Like
I know.
this whole food is medicine started. You should see, like you get a prescription for food.
I know.
As
I
part of the
know.
hospital. So that's what I say. It's like
Hospitals
it
are
isn't.
jumping on board. This is something that I hope we get to be more involved in. I like Tufts has an entire institute dedicated to it. I mean, I agree with you, Justin.
BMC was at
I
the
know.
forefront. They were the first to have a food.
But our systems haven't come together to acknowledge this. So, anyways, all right.
We're all passionate
If
about it.
people love hearing about food and wellness and all that, tell us.
Let's go
so
have a
we can do
cheeseburger,
another.
right?
Yeah. So we have to wrap this thing up. I think we talked about a bunch of really good stuff. So my 2 were food, the food industry, and then artificial intelligence. Dave?
Telehealth expansion and reducing administrative burdens.
And
Walmart with virtual primary care, and Ozempic, and what was the other W?
it was like a Wegovy or
Wagyu,
something. It was
right,
like very
Wagyu.
exciting.
Yeah.
Wagyu, it was like the beef that we had. We need to talk
Like
about
a-
that restaurant last night. Okay. Thanks again. I'm Ellen Brown.
I'm Dave Pavlik.
I'm Justin Politti.
We're the partners at BP2 Health.
Your chance for real change.
No, it's the best chance. For
The best chance. What did I say?
Just chance.
Your chance.
As you can tell, we could talk all day about healthcare.
Yes.
Drop us a line at bp2health.com. Reverse Mullet podcast is produced by Kim Rittberg and Emily Newman with Henry Street Media.